Hi, I'm Dr. Rhett Polka, and today we're shooting a follow-up video to the one we posted last time on YouTube, which covered what a 180 physical therapy follow-up visit generally looks like and what it entails, and most of our thought process. At the end of that video, I encouraged people to please send us questions. That video covered a lot of information. I'm sure there had to be things that we didn't quite cover enough to make it clear. So what we're going to do today is go over a few of those questions that we got, and we got a ton of questions that were really good. We got two phenomenal questions that we'll save for the very end. But here's our first question. First question was, are there certain patient populations that the 180 system works best with? And the answer is yes. Typically, the 180 system works really well with athletes, but it also works really well with sedentary people. Most young people respond really quickly, as do old people, and very athletic people and people who have desk jobs also respond well, as do obese people and thin people. So the answer to that question is everybody responds very well with this system because it's based on human physiology. So in the last 11 years that I've been doing this, I haven't had one patient that hasn't responded, and we see everybody from Little League athletes to 85-year-old grandmothers. We see obese people that we can still palpate on. We'll teach you how to palpate with those people when we go through the class. But long story short, there isn't anybody that doesn't respond. Some people respond really, really quickly as far as number of visits, and sometimes it's people that you don't think are going to respond that fast. So if we take somebody who has plantar fasciitis and they've been wearing orthotics for 10 years, we think, well, maybe we'll be able to wean them out in a week, maybe 2 weeks. They'll come back for their second visit 4 days after their first visit and say, I took my orthotics out and I haven't had them in since. So some people that you don't think are going to respond all that quickly will respond really fast, and sometimes somebody that you think you'll get better in 1 or 2 visits, it might take you 3 or 4, and there's some things that we'll teach you as we go through the class to look for different compensations and how they compensate differently and why it might take them longer than you think. But the answer to that question is this system works with everybody. Our next question is, what does this approach look like? How does it work when treating patients whose pain or disability levels prevent them from tolerating the NFTs? I take this question in 2 ways. One, either they can't tolerate or get in the position of the NFT, or they have pain during the actual test. So I'll answer it both ways. So if a patient has a problem getting into position or has pain with the positioning, let's say we have a frozen shoulder and we need to position them in the end range of either abduction or flexion. If we can't get them in that position, what we can do is open up that motion with MOBs. So we can use MOBs to help us out in getting a little bit range of motion to get patients in positions, because if we can't get you in the position, then we can't do the test accurately. So we'll do MOBs to help get us into positions, but then we go back and we'll teach you in this class how to clean things back up after you MOB somebody. The other issue could be somebody has pain. We do have on occasion patients who can't get on the table because their pain is so severe. All of the tests that we do, all 150 tests are done on the table, either in supine or prone. So if somebody is having problems getting on the table in either supine or prone, we can start them off by doing some things seated or standing, but eventually we need to get them on the table. The second part of that question, as far as having pain with the actual test, if they have pain with the test, it means one of two things. Either you're doing the test incorrectly because you've got them in a shortened position. So let's say we're testing long head of the bicep, and that crosses both the shoulder and elbow. If we go in the extreme range of motion and put them in a short position and test that, we're going to get active insufficiency, which is going to cause a really hard, uncomfortable cramp because the muscle is all the way in a shortened position when we ask it to contract. That's why we don't ever test muscles in the extreme range of motion. So you're either doing the test incorrectly or you're doing the test correctly and you're getting the response that you should be getting. So let's take, for an example, we have somebody come in with low back pain and we test their right rectus femoris. We test the right rectus femoris and it elicits left side low back pain. That tells us that the rectus fem is not contracting because of neurological inhibition, And what that patient has learned to do for compensation is contract the left side lumbar extensors, which is why they have low back pain and they're coming in the first place. So if we go back and we treat the right rectus femoris, which failed the test and caused the low back pain, we test that again because we always come back and check our work just like we covered in the first video. We check it the second time, and now we no longer have left-sided low back pain, and we have a good contraction of the right rectus fem. That's what teaches us that the pain isn't always where the problem is, and that's a fantastic example of the law of reciprocal inhibition. So if you have pain with the tests, after you get them in position, you're either doing the test incorrectly because you have them in a shortened position or the wrong position totally, or if you're testing a muscle that elicits pain somewhere else, that means that that muscle is failing the test, and their compensation pattern is to use the muscle that's causing the pain response. Our next question also has to do with pain, and the question is, how do you work with somebody who has pain or can't tolerate the manual therapy? So our manual therapy will have certain muscles that usually elicit some type of pain because you're digging to get to a deep muscle. This could be iliopsoas, this could be subscapularis, or it could be a superficial muscle like the serratus anterior, which actually inserts onto the slips insert onto the ribs, and ribs are painful. Even though we're going to the muscle belly to treat, we're still going to hit the rib, which will cause some pain. So some of the palpation positions will elicit a pain response with just about everybody, but not everybody should be painful with every single palpation. If they have pain with every palpation, then you're palpating incorrectly. Remember, we're only trying to get to that muscle belly and get enough palpation to get pressure on the neuromuscular junction. Like I said, some people will have some pain with that and some people won't. What you should notice is people that are really painful on the first visit, on subsequent visits, that pain response decreases because now they're getting used to what you're doing, and you're increasing proprioception, you're increasing muscle spindle sensitivity, and you're doing less and less palpation as you go through the visits because hopefully you're treating them correctly and they're following up with their home exercise program. Therefore, you should be treating fewer and fewer muscles at subsequent visits. Our next question is, it sounds like what you are telling patients is the opposite of what they've been told before and or contradicts much of the conventional thought process. Yes, that's correct. How do you get patients to understand the 180 system and believe you? It comes down to three basic things: educate, demonstrate, and results get returns. So as I went through on the first video, we spend a lot of time educating patients throughout their time here so they understand what we're doing, and most of the time in the first visit the light bulb turns on and patients have that aha moment where they understand what we're doing and why it's different than everything that they did before, and why we don't tell them to do the same things that their other physical therapist, chiropractor, athletic trainer, whoever told them to do. So educating the patients goes a long way, but not all patients can follow this stuff. So if you've got somebody who's younger, say I've got a middle school student and I'm trying to teach them about physiology and things that they don't have any understanding of, it helps to demonstrate. So we do a lot of demonstration, especially with patients who are, let's say, gymnasts or dancers, and they don't understand what we mean when we say stop stretching, because that's one of the things that's making you worse. Same thing with, we've had a huge explosion in the CrossFit community, and CrossFitters love their foam rollers, so when we tell them stop foam rolling, they don't understand that. The best thing to do is demonstrate. So we'll stretch them, we'll foam roll them, we'll show them how strong they are before we stretch them or roll them, then do those things to them, come back and retest, and they can see how much strength and control and stability they lose just by stretching something 10 seconds or just by rolling something for 10 seconds. So demonstration and feeling what happens goes a long way. The other thing that'll happen is they'll come in, had a CrossFitter that was huge on foam rolling, was foam rolling and stretching all the time. Came in, we convinced him to stop foam rolling, and he came in for a follow-up visit and said, well, it's really weird, my measures, my performance are through the roof, but I still don't understand what's going on with my body because I'm not foam rolling. And I said, well, what does it feel like? Do you have more pain or what's going on? And he said, no, it just feels really weird because for the first time ever when I lift, I feel stable and I feel stiff. And I said, that is exactly what we're trying to make you. We want you to be stiff because that means the joint is stable and your muscles are stabilizing it and they're strong and they're producing stability and strength through the full range of motion. And stiffness is what you want because that means every single muscle is contracting at the right time and you have give and take on both sides of the joint. Whereas before he felt loose because he had no control on any side of the joint, which is why his performance went down, and after he got done working out, his body fell apart. So education and demonstration go a long way, and the other thing that really works with patient education is just results. When people come back for their second visit and say, this is the best that I've felt in years, and all I did was the 3 exercises you guys gave me and stopped doing all the bad stuff, those results are what make our patients go out and tell all of their friends, their family, their coworkers to come back to see us. So some people education works really well with. Just about everybody demonstration works really well with. But at the end of the day, results are what gets you returns, and that's why we've been so successful, because once you fix people's problem for the long duration and you're not doing it with symptom modification, they come back. Okay, now for our last 2 questions, which were my favorite. The first one was, I like the approach and of course how the focus was on the function specific to that patient. I'm just interested in any research regarding the outcomes with this specific approach. This is one question that we get over and over from physical therapists and a lot of physicians who hear about us and want to refer patients, which kind of gets me to chuckle a little bit because they want to know about evidence-based practice and research that we've done on this system. But for those physicians that send us patients, their referral script has things like ultrasound, traction, stretching, massage, all the things that have been refuted in the research, but yet they still refer to physical therapists that do that, but they want to know what our research says on our specific approach before they refer patients to us. So I can't wait to entertain that question, and we will soon. The second best question that we got, which we hardly ever get, and I'm glad we got this one, is what is your definition of functional movement and or exercise? So over the last, I'd say, year, there's been a lot of videos posted on the internet, YouTube, that call themselves functional exercises. So if you understand the recipe for injury, there's one one ingredient in the recipe for injury that always comes up with functional exercise, because in our book, if you don't have the transverse plane motion in your exercise, you do not have a functional exercise. The other thing is functional exercise has to be functionally specific to the patient. So if I have a baseball pitcher coming in, I'm not going to give him exercises in quadruped, I'm going to give him exercises in stance, because he doesn't pitch on his hands and knees. So I can't wait to give you guys a video of some of our functional exercises and what those look like, how they integrate the transverse plane and functional movement patterns for specific populations. Since both of those questions are really good and really in-depth questions, we're going to post videos for each one of those questions coming up soon. So stay tuned, and we'll talk about evidence-based practice and what we've done here as far as studies that we have going on now, little research projects that we've done, what's in the research out there already that shows that what we're doing works because it's based on anatomy and physiology, and another video on functional exercise. So stay tuned for both of those videos, and once again, if you have questions, send those to us and maybe we'll pick those up on the next one too. Until then, think different, live well.